morning. Doesn't that view just put you in a better mood? It does me. And so, welcome to your world. My name is Olivaro, sitting in for Winnie Lubembe. Allow me to do one thing, otherwise I will get in trouble. The previous show, AM Live, we're discussing the 16 days of activism against SGBV. And Athal Kwemba, who is the ED, African Women and Child Feature Service, said, you know, these guys are also critical sector players. It's a critical sector in addressing that. The referral... what's the technical term? The pathway, referral pathway. So the toll-free number that was spoken about during the show for those who may require assistance is 0800-720-587. The national line is 1195. I believe it's SMS. Yes. Okay. All right. So now we transition to issues to do with antimicrobial resistance, preventing antimicrobial resistance. And with me in studio, you know, when they say you should know people, you should know me. I have Doctor. So we have Dr. Allow me to start with, I know you're in the minority today, Dr. Ismail, but allow me to start with the ladies. We have Dr. Sharon Odell, who is AMR, Antimicrobial Resistance Lead at Ecumenical Pharmaceutical Network. The AMR, I'm right? Okay, good. I thought I was making, I would end up with some egg on my face. We also have Dr. Reno Omoro, Kenya Dental Association, and we have Kenya Medical Association, KMA. Correct. The IPC you'll have to assist me with, but IPC stroke AMR, Antimicrobial Resistance Working Group. The IPC? Infection Prevention and Control. Infection Prevention and Control. Yeah. So, Dr. Sharon Odell, I will ask you to please assist those of us who may not be familiar with antimicrobial resistance. This AMR, what is it?
Thank you so much, Olive. AMR, it's a very technical term, but I will try to simplify it as much as I can. AMR, in full, is antimicrobial resistance. This is just a term used to describe the fact that medication that is used to treat infections are no longer effective. Why is this happening? We find that most of the microorganisms that are causing diseases, be it bacteria, be it viruses, be it fungi, be it parasites, they are gaining genetic mutations and working against the treatment that actually works against them. How is this happening? What is happening right now is that this bacteria or these microorganisms, they're getting exposed to suboptimal doses or subtherapeutic doses or small doses that are not strong enough to be able to kill them. And once this happens, they're also living organisms. They have to mutate and come up with defense mechanisms against these drugs that are attacking them. So over time, since they replicate very fast, for example, bacteria have a replication rate between 4 to even 20 minutes. Every 20 minutes, they're dividing into 2 different cells. So if this resistant gene is in one, they're replicating very fast. So over time, a drug that used to work against that bacteria is no longer effective. So I hope I've demystified this very heavy mouthful term, but in a nutshell, that is what AMR is. Okay. Yes. So
because the theme for the week 18th, it was 18th to the 24th, yeah, was preventing antimicrobial resistance together. So it means there are many players, and yourself, you who is watching, also have a role to play. Yes. But we'll get into that. But as you can tell, I am struggling with a little bit of Homa. But before the doctor upstairs, so we have a Meridian clinic on the 11th floor, prescribed any medicine, she said, you know, let's do a blood test. Let's establish if what you're suffering from is bacterial or viral. She said she doesn't want to prescribe antibiotics unnecessarily. Is that what we're talking about, Dr. Ismail?
First of all, for the introduction, thank you for the invitation. It's important that Nation Media invited us. It means they are stakeholders in this, and we are very happy as a Kenya Medical Association for this partnership. So we need to understand that we have to prescribe an antibiotic when in need, because for a long time we have been having problem with resistance. Just a short history. In 1928, Alexander Fleming discovered penicillin, and it ushered in a new era of antibiotics. and it was a very wonderful era. We could treat infections which before they used to kill people. We could do surgeries with ease, and we could do chemotherapy and organ donation. So the result was we had an increase in lifespan. Now the problem is, even before we reach 2028, a century, we're having a problem with resistance. Now we need to take action, and it needs to be immediate. Now when we come to now antimicrobial prevention, when you come to the hospital, we have to do this test, because what could be the drivers of antimicrobial resistance? One of the driver is the demand of antibiotic from the population. So when you come to the hospital, you may not need that antibiotic. That's why we'll need to do the test. If the test shows it's not a bacterial infection but a virus, we may just give you some analgesics and avoid antibiotics. But also
analgesics are what?
For example, drugs which could reduce the pain or the inflammation.
Okay. Managing the symptoms.
Managing the symptoms, because you really don't need the antibiotic. And another driver for antimicrobial resistance, number one, is somebody usually takes antibiotics. It could be for a good cause, but he takes it for a short duration. The doctor prescribed for 5 to 7 days, but he took for 3 days. And once he felt better, he left the medication.
But why do why do you want me to poison my system with medication I don't need? If I feel better, dawa imefanya kazi yake, I move on.
No, because it usually needs enough time to kill the complete population of the bacteria. So if I take for 3 days, some populations have been killed and some have not, then they can re-emerge with resistance. That is the effect of a suboptimal exposure, which my panelist was talking about. Also, another reason could be somebody could be having antibiotics. He has stored them in the house and he feels he's having quote-unquote similar illness.
Yes.
Then goes and uses that stored antibiotic, which this time could be a different antibiotic bacterial infection. Another cause could be one of the family member is having antibiotics which he had used. Now when a relative gets a similar quote-unquote condition, they share this antibiotic, which could be a problem. Also another cause could be some antibiotics, they need to be taken for a long time. For example, antibiotics against tuberculosis, you have to take them for 6 months. So this now becomes a challenge. If you don't have good compliance, after 2 months the patient is feeling well, he may completely stop using them and they resurge.
And it makes it more difficult to treat.
Correct. So we need the test to just confirm you have bacterial infection before we can treat. So we urge the public to kind of listen to your health care practitioner and follow the advice.
So, I mean, when you go to hospital, when the doctor is prescribing, right, medication, so that thing of 3 days, for 5 days after meals is not just random, like the doctor just said, this one looks like 3-5 days, they're not too sick. That's not random.
It's not random because there's some minimal time which they have to be exposed to completely eradicate them. That's number one. Number two, we have some antibiotics which they have to be taken 2 hours after a meal, for example, azithromycin, or 1 hour before meal, just to enhance its absorption. So they should really adhere to that advice. There are some antibiotics, for example, metronidazole, Flagyl, which when you take also, you shouldn't take alcohol because of the adverse effect. So these are some of the advice which we usually give to help take care of the patient and also prevent resistance.
Okay, so listen to your doctors. All right, Dr. Reno Omoro, Kenya Dental Association. I learned my lesson the hard way to listen to doctors. I went to have, so I had a tooth that was not one of my wisdom. What's the word?
Your wisdom teeth.
Yes.
Impacted.
Yes, that he was impacted. And I remember the doctor advised me, take your painkillers. In this case, it was painkillers within this period of time. But I was feeling fine. Hey, when the pain hit. I was like, why did I not listen to the doctor? So, I mean, how much of a challenge do you usually have getting patients? Please, just follow these instructions.
Yeah, the problem, especially in the dental field that we experience, is the moment a patient's pain has been handled, that's it. So we get the general public not taking their oral health as seriously. So when they get some pain, they rush to the nearby pharmacy and go get antibiotics. And then they're taking the antibiotics. And then when the pain disappears, because probably the inflammation that was there has gone down, has subsided, they stop taking the antibiotics, so they haven't finished the dose. and they were probably taking antibiotics unnecessarily. Because the thing with dental condition, most of them can be sorted out with dental procedures. So you don't have to take antibiotics, or you don't have to be prescribed for medication unless necessary. So the thing is, we are facing a lot of challenges because we want the general public to have antibiotics available for them when they need them, and we want you to be able, for them to be able to work for you when it's necessary. So dentists, yes, we prescribe antibiotics, but in situations that are necessary. When you're prescribed for example, just painkillers, you're supposed to take the painkillers, because we already know if you don't take the painkillers, the inflammation could get worse. So the main challenge we face as dentists is people rushing to get antibiotics for dental conditions that can be sorted out with a simple dental procedure. Yeah.
Oh, you have something to add to that, Dr. Ismail?
Yeah. When it comes to pharmacy and the pharmacy outlets, I think
and we have a pharmacist. She's here.
She's here. I think we have a challenge because one of the things, the pharmacy outlets need to be kind of regulated, and also from their practice, they need to appreciate the importance of a prescription from the healthcare workers. For example, a woman could go to a pharmacy who is an expectant lady and buy some antibiotics, which she had used previously, but this time she's expectant. When she takes the antibiotic, it will harm the baby, because there was no healthcare practitioner who prescribed it. So that's the danger of it. Yeah, so we need to kind of have a conversation around it. They need to have some regulation and also integrity on the dispensers of the drugs, because sometimes we usually have drugs which are contraindicated to certain age, for example, children and expectant women. A simple antibiotic will be ciprofloxacin. We don't want to give it to pregnant ladies because it will cause complication to the child, or tetracycline. It will affect the bones and the teeth of the growing fetus. Yeah.
So I mean, so self-medication, you guys are saying, no. So we'll come back to the drug interaction bit of things. But Dr. Sharon, when Dr. Ismail was speaking initially, and he was like, you know, when there's medication that is left over, or you know somebody who has similar symptoms, and then you should not take that medication. I'm like, but I'm simply saving time and money. And then, and for going to a clinic, imagine, unaenda unakapo kwanza, mnafanya, what is that thing you guys, ile assessment ya nurse anaangalia temperature, triage, unafanya triage. Although I get the sense, because you want to understand the severity of, does it require emergency intervention and all of that. So triage, then I go back, I sit there, and I'm coughing, and my nose is running, and I'm just feeling horrible. Then I have to fill forms, then my insurance has, sometimes it's just simpler to go to the pharmacy. Especially when you're like, I have felt like this before, it was a cold. Why is it important to go and see a doctor, Dr. Sharon, as opposed to just go directly to the pharmacy?
Well, the sad reality on ground, or actually the actual reality, let me not even call it sad, is pharmacy is actually a primary point of care for many Kenyans who cannot afford, number one, to visit a healthcare facility, or number two, like you said, the constraints of time and waiting in the waiting bays, as well as exposure to other medications.
I'm fortunate I have insurance cover.
Imagine. Yeah. What about those people who can't even afford even the simple NHIF that we have already? So pharmacy is usually the first point of care for most Kenyans. But if you are to follow the rules by the book, antibiotics, antivirals, all these are prescription-only medicine. If you check your medical, the packaging of your medicine, it has POM, meaning prescription-only medicine. Ideally, no pharmacist, no pharmaceutical technologist in your pharmacies should actually dispense it without a prescription. So in most countries, if you travel out of Kenya, you'll find that it's very hard to access these antibiotics over the counter. But in our setting, due to, we have quacks who are operating pharmacies like retail shops. We also have, unfortunately, some of our profession who actually look at the profits and not the benefits to the patient. They actually sell these antibiotics, which is very unfortunate. So it is very important, if you're feeling sick, like you've said, you had a flu, you had symptoms, you didn't know if it was bacterial or viral. That is too technical. You just know you're down with a flu. It's important for you to go to the hospital, because once you go to the hospital, they'll be able to do the necessary tests. You'll be able to know whether it's caused by a bacteria, you get antibiotics, whether it's caused by a virus, you manage the symptoms, or you get a anything, because you know viruses are not curable. You only give drugs to lower the viral suppression, to just suppress the virus load. So you manage the symptoms, and since a flu is self-clearing, most of the time it's viral and it's self-limiting, meaning after 7 days it's gone, whether you treat it or not. So you just manage the symptoms. But if you just sit by yourself and decide, okay, my throat feels a bit raspy, let me go to the pharmacy. My friend used this drug, azithromycin, and it worked. Why not go for it? You're given that drug, you're told, oh, take for 5 days or take for 3 days for azithromycin. You're asking yourself, what is the need? You take it the first day, the second day, you're done. That means the whatever bacteria is in your body, whether it's the one causing the flu or not, they get exposed to azithromycin for a day. So some bit of it dies, some bit of it remains. And the ones that remain, they've been exposed to a small amount of azithromycin. And now they know, azithromycin attacks this and this part of my body. Let me gain resistance. So I change my genes and block wherever the azithromycin is attacking me as a bacteria. And I remember, they replicate very fast. Every 20 minutes, they're replicating, dividing into new bacteria. Over time, that bacteria that is in you that was exposed to small doses of azithromycin becomes resistant. The day they replicate to a level where they'll cause another infection, you won't be able to treat it. Or now you'll have to move to a very expensive antibiotic. Now the issue of affordability, availability comes into play. So it is very important to seek medical advice.
But you know, I'm thinking that you all look very nice and young. But I mean, for years, you've talked about azithromycin. Ni kama hata naweza jiandikia prescription. I know it. I've been given that dawa. I know. So I mean, people have been doing this for years, going to pharmacies and they are given across the counter. How are you feeling? Symptoms. Okay, so we meza hii na hii na hii. And people are saying, hey, janidhuru. When did you make this discovery? Maybe they are saying it has come with these young doctors.
So to chime on that, with time, we have been seeing resistance in the hospital. For the first time, it didn't cause harm. But now, with the development of resistance, when we admit them in the hospital, is when we are getting into troubles. So we are seeing patients taking longer time in the hospital. They used to come, you give them medication 3 to 5 days, you discharge them. Now they are taking 2 weeks because of the problem of resistance. Now, so you have more cost in terms of hospital stay. Now you have to use expensive medication, and sometimes patients end up dying. So we have the burden of mortality, the death. We have the burden of, in terms of cost, they are spending more for the long stay in the hospital, and we are spending more in terms of requiring a newer and more expensive antibiotic. And we need to understand one thing. It takes around 10 to 15 years to develop a new antibiotic with $20 billion you have invested in that. Now, in case you are having resistance of like 10 antibiotics in a span of 5 to 10 years, so we'll be overtaken. Now, this brings us to my worry. When we ushered in the antibiotic era in 1928, what we are now, we are on the verge of expending all the antibiotics, and we could move into a post-antibiotic era, whereby there's no any antibiotic which is working, and simple infections will be killing all of us. That is our worry as a healthcare professional, to prevent us not to tether and fall into the post-antibiotic era. So the problem, you have seen the cost in terms of the financial is enormous. In terms of the human life lost, it's big, and we can't afford this. So we need to protect the few antibiotics which we are having, so that we don't move into the post-antibiotic era, whereby simple infection will be killing us as before 1928.
All right, so we need to take a break, Dr. Reno, but I will come back with a question for you, because if I know a doctor, hi, Dr. Marie Claire Wangare, say I can just call and tell her, you know, I'm feeling like this and like this and like this. And then she'll tell me, okay, take like this, like this, like this. And then, or even during the COVID era, people found it difficult to access health services. So how with tech are you handling now the prescription of antibiotics for those people who are in remote areas and perhaps they can't access a clinic as easily because it would involve a trek of several kilometers, time taken from their day that they could have been doing other things, or they're too weak to leave their area of domicile? On the other side of this break.
Haya, ulisubiri kwa hamu kuyasikia matamu ya Lamu.
Lamu town is the World Heritage Site. We are custodian of this culture.
Utamaduni, punda mashindanoni, magwiji majahazini, utakosa kwa noni.
Singing is amazing, the art's amazing, the food's amazing, and the people are amazing.
Tuna raha tukiwa na hii mashindano.
Tamasha za tamaduni Lamu. Lamu Cultural Festival kuanzia tarehe 30 Novemba hadi 2 Disemba. Kikosi timamu kimechukua hatamu angani, majini na kisiwani. Jarida la Lamu. Ukifika Lamu itakuwa bamba.
Want to know the biggest story of the week? Do not worry. The Weekly Review got you covered. For in-depth analysis of politics, business, governance, as well as social issues, the Weekly Review covers it all. For well-researched, exclusive and investigative content, read the Weekly Review every Sunday in the Sunday Nation.
The Sport Essence is a light serum, quickly absorbed to clear dark marks. Rich moisturizing cream is a gel cream type that deeply hydrates and prevents dark marks. I highly recommend Melano CC for healthy and happy skin. Roto.
You know that ad. Okay, welcome back to Your World. My name is Olive Burrows, and we're discussing prevention of antimicrobial resistance. Dr. Sharon was kind enough to explain simply as she could possibly what AMR is. But Dr. Reno Omoro, I was asking, in situations where access to a healthcare provider, physical access is difficult, how do you go around that?
Now we have to first remember that our current healthcare needs should not compromise our future healthcare needs. So it is possible to assume that as long as I can take care of this right now, it is fine. But when we monitor the trends of antimicrobial resistance, it's really worrying. Currently, the studies show that we get about 700,000 deaths per year from antimicrobial resistance. But they are saying by 2050, it's going to be 10 million annual deaths from antimicrobial resistance. So it's a global concern. It's something that we need to take serious, and we need to focus on it. So the thing is, that's where we come in with the Kenya Drug Authority. There's been this discussion about a pharmacist being the minimal requirement to run pharmacies. So we have other paraprofessionals involved in that department that need to work under pharmacists. And this is because pharmacists are actually trained and they know the effects, they know what can be prescribed for what, and that's why it's important. So you might be in an area where it's hard to get a medical officer, but if you have a trained pharmacist who knows, okay, you're saying you have an inflammation around your gum, you need this, instead of prescribing a strong antibiotic that in the long run you might develop resistance to. And the thing with resistance is you can develop it and you can pass it over to other people.
What?
Yeah.
How?
The thing is, okay.
And Dr. said you want to come in and assist. Hey, Dr. Reno is like, there's a reason we went to school for 6 years. How many years? 6 years, 7. Yeah, she's like,
No, I got it it's very exciting because you remember in March, there was super gonorrhea. So for the Kenyans, it's very easy to understand the resistance. So what do you mean by super gonorrhea? So it's a type of gonorrhea which has developed resistance to many medication. Let's talk about tetracycline. It's resistant to it. Fluoroquinoline as a group is resistant to it. Yeah, sulfonamides, it's resistant. You go to the first drugs which you are using like ceftriaxone and azithromycin, it's resistant to it. And it's a sexual transmitted illness. So during March, there was a lot of talk in town about supergonorrhea, transmitted through sex, but others could be transmitted through like coughing and in the same environment. Yeah, so you can pass a resistant bacteria from one person to another through a myriad of ways. And that's what usually concerns us. Now, I need to mention some prevention aspect on that. If it is a waterborne infection, we can talk about WASH. That is water, hygiene, and sanitation. Washing your hands, that is, we are talking about infection prevention. Washing the fruits before you eat. We can talk about wearing mask. When you are visiting patients in hospital who are like in special wards, like tuberculosis wards. Number 2, restricting your time when you visit the hospital because we have a lot of resistant antimicrobes in the hospital. So restrict your time.
You see, I told you.
Yeah. So restrict your time when you are visiting a patient. But also another aspect, for the sexual transmitted illness, there's a role of prevention. Like for the young people, adolescent, we can say abstain. But for the married ones, use condoms to prevent the passage of things like supergonorrhea. So these are our roles. But now when it comes to testing, where we started by, and the aspect of telemedicine, we have to give a role to telemedicine. But I know there are some companies which they have framed it very well and have organized it very well. So you can contact a doctor through call. He can listen to your symptoms, and they can even send somebody to come and collect your blood so that they can do some test on it. So
no, but I am in Mandera. So I am in Mandera. I am sick. I am in...
We can use telemedicine, but at least talk to a healthcare provider, then he or she will advise you. But
my phone is Nini.
I think in Mandera this...
No, I'm kidding. I'm not saying Mandera. Okay. Clearly, I'm wading into a minefield there. But Dr. Sharon, before we get into disposal, they did host a show once or twice with the World Animal Protection. And it was on antimicrobial resistance. And I asked myself, what do pigs, chicken, and cows have to do with this thing? They don't take penicillin. You took us back to as far as 1928.
That is when the invention of medicine and medical practice started from. So it's a very important year for us as medics. So back to your question on the importance of where does animal health chime into AMR? I mean, I think animal health right now is one of the major drivers of AMR. And this is how it actually happens. Antibiotics are the same molecules that are used in human health as well as in animal health. The same penicillin that is treating a human, the dosing will be different, maybe the dosage form will be different, but it's still the same molecule being used in animal health. As of now, there's not too much emphasis, restrictions, guidelines that are being strictly followed within the animal health practice. So you find farmers who are keeping chicken at their backyard, people who are doing large-scale farming, they already know maybe my chicken is susceptible to getting chicken flu. From my neighbor who also does chicken farming at a larger scale, there's a certain antibiotic that he or she uses that helps the chicken fatten faster and also prevents the flu. So I just get the name of the drug, I go to the nearest vet shop, purchase that antibiotic. I don't care about the dosing. I can just mix it with water, put it in the feeds or in the water that the chicken are taking. So what happens is if this chicken, once they take antibiotics, there's a lot of genetic stuff that happens and they grow faster. Within 3 months, they still have the antibiotics because they've been feeding it and no one is regulating the doses. It's in the meat. How often do we take chicken? How often do we take meat? How often do we take pork? this is something that is on our tables every other day. So we are getting a lot of cases where us as humans, we are consuming antibiotics, not just by prescribing by ourselves or taking when it's prescribed, but also through our food. There's antibiotic residues in the meat that we are consuming. So over time, still the bacteria in your system, the bacteria in the environment is still getting exposed to small doses of antibiotics. And like I just mentioned, it's the same process that happens. Once this bacteria is exposed to something that attacks it, they always find a defense mechanism. And once they do, they change their genetic makeup, replicate, and now we have a new breed of bacteria that is very resistant. So that animal health is also a very main player in causing AMR, and that's why now we have the aspect of One Health. One Health now incorporating environmental health, we have animal health as well as human health, all coming together to be able to have interventions to prevent AMR, because they're all intertwined. AMR is very broad, it's very multifaceted, so if we only approach it from the human health perspective, we're still eating antibiotics in our meat. So we have to take a
holistic approach.
Yes.
Okay, but again, you're making the point of the together, preventing antimicrobial resistance together. Like, I mean, you have to take your full dose. You should not be taking antibiotics without unnecessarily, and also the strength of the antibiotic matters. You should, even how you dispose, I imagine, Dr. Reno, matters how you dispose of this medication?
Yes, because when we dispose these medications to the environment, or even the chicken feeds, the products from chicken, we're exposing the environment to these bacteria that have grown resistant. We're exposing them to the genetic components that confer the resistance to them, and we are also exposing them to waste products that just can expose us as humans to the environment. So we have to manage waste in a way that we are not risking the transfer of this bacteria. So
how
waste
do you
management.
Okay, so first just finish your dose, so that there's
so that you don't have to throw them
away. You don't have to throw them away. Okay, but there's also this climate change, manenos. Climate change, big issue, COP28. And so my understanding is that we have new diseases that are caused or have come about on account of climate change. How does that then impact this 1928 penicillin?
So among the top 10 global threats, apart from antimicrobial resistance, we're also having climate change. And for a Kenyan, even at the mashinani, they understand now what climate change means. You know, it used to be like these were big talks on the international level, but currently with the El Nino, currently with the changing patterns of rain, you know, December used to be a very dry month, but we are seeing now a very wet December and January, so we are seeing some climate change pattern. Now, how does this interfere or interact with the antimicrobial resistance? The first thing, when you are having changes in climate, for example, the weather is becoming warmer, it means some diseases which were not in certain areas, they may start now encroaching into those areas. For example, malaria in cold areas is usually absent. But now when the temperature starts going up, now mosquito will start coming to that area and people start being affected by malaria. That's number one. Number two, there are some bacteria like, which cause diarrheal disease, like Campylobacter. They thrive so much in warmer environment. So also it will really affect us. But the third aspect, with the coming of flooding like El Nino, a lot of water will come, they'll overrun our sewerage system, which now will expose the dirty water to the population, causing more infection. But also that these floodings will cause people now to move to one locality, causing crowding and spreading infection from one person to another. So climate change really has a very big role to play, and we need to handle it in tandem with efforts to prevent antimicrobial resistance. Yeah, another issue also with deforestation. You know, when we are cutting trees, it usually makes the human being and the animals to come into contact as we are encroaching the environment. And since we are post-COVID-19, you remember COVID, it was a viral infection which came from a bat to human beings. So that's how climate change, deforestation, contact between human beings and animal, when they come closer, cause this problem. And which brings me back to One Health policy. Now we need to tackle the environment aspect, the human health, and the animal health. Because you remember in animals, we usually have 3 problems as Dr. has elucidated. Number one is putting antimicrobials in feeds to encourage growth. But number two also, there's something we call prophylaxis. The disease has not struck, but we give them medication, animals, to prevent them from getting disease. But we have another, a bit expensive term, metaphylaxis. One animal has been affected by a disease, now we treat the whole group. So which causes us now the amount of antibiotics which are consumed in animals is 4 times the amount consumed in the human health. So we need a big concern when it comes to veterinary medicine and agriculture in general.
Metaphylaxis.
Metaphylaxis.
Learn something new. And you already, I'm listening to you guys, and you're speaking about what needs to happen in terms of regulation and all of that, especially where veterinary practice is concerned. I had asked for water, and I've realized you guys don't have water.
Okay.
I'm so sorry. I'm really sorry about that. But yeah, so now in terms of what are the gaps that we need to be paying attention to. I know you've already talked about animal health, the interlinkage between animal health and antimicrobial resistance. What are some of the other areas, Dr. Sharon?
Just to clarify, is it the challenges, or is it other ways that we can actually put in efforts to combat AMR?
Let's start with challenges.
Okay. So just looking at maybe from the human health perspective, we always have proper guidelines and standards as to how we can be able to use antibiotics well or antimicrobials well, but we have challenges on ground that impede that. Case in point, you go to a hospital, your doctor does all the tests, it's confirmed, and you know you have a bacterial infection, and they prescribe. Get to the pharmacy, and you're told that drug is out of stock. Where does it put you as a patient? It means you're exposed to having to source out that medicine outside. Outside, you don't know who you will meet, because we can't assume all pharmacies are actually legal, because there's a lot of mushrooming of pharmacies in the country. So you might end up going to a pharmacy, but the person operating it is not a professional. That is not a registered pharmacist or an enrolled pharmaceutical technologist. You are at their mercy, because they will either change the prescription, which is not allowed, but at the same time, when you're at the pharmacy, sometimes people have the leeway of determining the cost or the price of your medication. So you might go, they tell you this medication is 600 shillings for the full dose, but you tell them, I don't have that amount of money. But because this pharmacy is close to home, give me at least half the dose. A professional will tell you that is not right, because if you're taking the dose, you have to take it complete because of not exposing that bacteria to suboptimal or subtherapeutic doses. But if you find someone who's not professional, they'll actually sell you the dose for 3 days. And you end up taking it for 3 days, and you feel better. You don't see the need of going back for the remaining 3 days dose. So that is one of the challenges that we are having. At the same time, we can't assume that all facilities have the capacity to do diagnostics. People just come, you say, I have a flu, raspy throat, I've been coughing, I just prescribe. Because our lab does not have the proper facilities, the reagents that are required to determine what is the cause of your treatment. Case in point, we also have patients who are admitted. They've been taking antibiotics for a certain bacterial infection, but it's no longer effective. One key test that you have to do is the culture and sensitivity testing. So what happens is, if it's a wound and it's not healing, you take a swab. A swab is like a sample of the pus or the cells around that wound. You take it to the lab. There's a culturing bit where you grow it in an environment that will enable that bacteria to grow within 2 or 3 days. Once it grows again, you isolate that bacteria and you test it against different antibiotics that have been scheduled or within the guidelines of treatment that should be working against it. So once you do now that is the sensitivity testing. Once the results are out, you'll know which antibiotics are not effective, which ones actually did clear that bacteria. And based on those results is when the prescriber or the physician will actually now prescribe based on the results. But what is happening on ground is not, majority of the facilities don't have the capacity to do this very essential test. And secondly, what is the turnaround time for you to do that test? If you're in the ward, it will take least amount of time, 3 days, for you to get the results. In between these 3 days, you're taking an antibiotic of which you're not even sure if it's effective. So once the results come out, that's when your treatment changes. If you can't afford that test, that's another case again. We are just shooting in the dark, trying to manage that infection. So there are very systemic problems within the healthcare facility that are also contributing to it. Coming to the human health again, regulation of practice. Most farmers, they undergo training, but do they follow the treatment protocols for animals? Once your animal is sick, ideally you're supposed to treat it, and once treatment is ongoing or once it's done, there's a specific amount of period where you're not supposed to slaughter that animal for consumption or even milk it if it's a cow and use the produce for human consumption. But when someone says the animal is not healthy, they've tried treating it or the treatment is expensive, I decide to slaughter it and sell it and make profit. Yet this specific produce is either sick, has a bacterial infection, or it already is exposed to bacteria. So there are very many issues, they're very wide, so I'll just leave it at that.
Wow.
Yeah.
And Dr. Ismail, I'm listening to Dr. Sharon, and I'm like, there are cost implications, what you guys are talking about. There are cost implications associated with following protocol to ensure that you're using the right antibiotics at the right time and all of that. But why, so with all the things that are clamoring for our attention, why does this matter? Why is it so important?
Now, this it's very important because we have seen the threat that it poses, the future threat. And this is where now investment in health comes in. And it's not like we are not doing anything. There's a lot of work which has been done, positive work by the government. So in 2014, the Kenyan government ratified the One Health policy and the fight towards antimicrobial resistance after WHO had seen that was the way and had produced their policy document. There's a national action plan already in place. So there's also a national antimicrobial resistant committee in the Ministry of Health and in the counties, some of the counties, around 30% of the counties, they have their committee, which is usually County Antimicrobial Stewardship Interagency Committee. So there's a lot of positive work which is being done on this. What we are just calling is more effort need to be put in place, especially what Dr. said when it comes to diagnostics. So we need to have lab tests like culture and sensitivity to be in hospitals. Currently, they are mostly in referral hospitals, level 5 and 6. But from level 4 going downwards, we don't have culture and sensitivity in most of these hospitals. So it will require the national government and the county's government to come and work together towards achieving this. And for us as a Kenya Medical Association also is where we play a role in it, because we have to encourage physicians and healthcare workers to use antimicrobials in a prudent manner. That's number one. But we also offer trainings and we do publications in our magazine. But also we are doing one in the World Medical Association so that we can work together to solve this issue. So if we see the future threat, it now calls upon us to double our effort. But there's a lot of positive work going in this field, and we thank the government, also the county government, the national and the county government for these efforts. But we just need to double up our efforts so that it doesn't catch up with us.
Okay. What I'm hearing you guys say is if you don't pay on the front end, you'll end up paying very expensively down the line. So, Dr. Reno, your final word on this subject. For the healthcare worker who is seeing, I don't even know how many patients in a public hospital, they are exhausted, they are underpaid, and they are overworked. It's a tall order, is it not? And they're dealing with very limited resources, as you clearly stated here.
Yes. So my word would be to follow the laid down clinical guidelines. I know it might be hard, but we already have set clinical guidelines which generally guide antibiotics and antimicrobial prescription. When you follow that, it would help reduce the global burden on antimicrobial resistance. There's a lot of resources online because this is a global threat. So all nations, there's international effort to combat it. So there's a lot of material. For example, the World Dental Federation has an online library where dentists can go on there and just read about guidelines, read about what needs to be done. There's online courses that are for free. We have the WHO action plan that can guide. So it might be hard, but there are some things that can still be done. For example, sensitization of the public. We don't need a lot of investment for you to tell your one-on-one patient that when you have this, kindly don't take antibiotics. This is what needs to be done. So there are some things that we can do on just following the guidelines, infection control and infection prevention and control, because we get that with infections coming up, it's exposing us to the antibiotics, which increases the incidence of getting antimicrobial resistance. So as an individual, as a healthcare practitioner, you might be exhausted, but you have to always remember what needs to be done for me to ensure I'm not passing infection from one person to another. For dentists especially, we are very keen on cross-infections, because in dentistry, we work in the mouth. There's a lot of things, aerosols going in, and we are one thing that is constant in our training, and the Kenya Dental Association has ensured that dentists have continuous training and learning on this, is that we have to prevent these infections, especially in our hospital settings, so that we don't unnecessarily expose patients to antibiotics or other antimicrobials, which would increase the burden of the antimicrobial resistance. So with our collective effort, individually, the general public and also the medics, we can do something to help reduce the global burden of antimicrobial resistance.
All right, so I know would only say so much in the time we had, but allow me to thank I know lawyers call each other my learned friend. What do doctors call each other? Doctor. We've had in the studio this morning Dr. Sharon Odell, AMR lead at Ecumenical Pharmaceutical Network, Dr. Reno Omoro, Kenya Dental Association, and Dr. Ismail Luta, KMA, IPC Infection Prevention Control, an AMR working group. My name is Olive Burrows. I've been sitting in for Winnie Lubembe. I have to make special mention of Dr. Marie-Claire Wangari, who brought this topic to my attention, and she's like, this is something you need to discuss, and for also putting it together. Have yourself a good morning.